repeated fracture, or 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing. Unlike conservative management, it provides stable fixation and early mobilization and reduces the risk of non-immune and mal-immune. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage, and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, no traffic accident was the main mode of the trauma, whereas fall from height and fall on outstretched hand was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation. A bump at the site of the fracture and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement, and the dead type of condition are the radiological indications for the surgical internal fixation with the plate and the screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures, either spiral or oblique or transverse or short oblique, 15D1 and D2. The patient tries to find the affected lip elevated and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the abduction of the fracture by closed width. The incision, a small incision, has a transverse or longitudinal incision about 1 to 1.5 centimeters. Just lightened to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of little bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take its own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate course of pain management and immobilization, after 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture, this is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see the 6-month follow-up, the beautiful radiological union. This is the functional result. You can see time is there. surgery. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science. 17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a collagen fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we call the collagen fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture, a 17-year-old gentleman, and the forearm collagen fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing. And ideal treatment for this collagen fracture is the plating, but I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for collagen fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of collagen fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the collagen fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we used 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for collagen fracture. So, but I left it and wait for it. This is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see, so after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union, it was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense swelling provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained and DR UJ should be reduced properly. We followed throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for galerie fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS yields higher union rates and excellent functional outcomes. This approach should be considered for galerie fracture in adult after further studies, because I think this is the first case in severe galerie fracture I did TENS. So this case was published in International Journal of Orthopedic Sciences. Provides stable fixation in earlier mobilization and reduces the risk of non-union and malunion. TENS is less invasive, resulting in smaller incision. After the study between March 2020 to March 2025, on 25 cases of the displaced fracture of the clavicle, the age of the patient was 16 to 48 years and no comorbidity was found in our study group. All patients treated with titanium elastic nailing. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation above at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, jet type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is the transverse and short of the fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 week. The 6-month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 60% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail background, superficial infection, and malunion, each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases, the radiological as well as clinical picture. As you can see, this is 15B1 fracture, and treated by titanium elastic nail. The post-operative case and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was used to reduce the fracture. Only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did. The 15B1 fracture treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation, and other at the entry site you can see that there is hardware from this. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with a plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
रेट तो पहले बाहर था अभी बोला था अब छोट बच्चा भी है उस साठों बांधे लायक नहीं थे अपने जुड़ गए बांधे के नहीं थे बच्चा का जुड़ जाए अपन 10 दिन में जुड़ जाए कहीं उठेला लेकिन फिर बाद में फिर बराबर हो जाएगा।
17 years old man, the road traffic.
Save time creating content and generate a high-quality clone of your voice with 11 Labs.
The traditional teaching that the 99.99%
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापर्टिनल नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैल्लेबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सिलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है और अब नेल को डाला जा रहा है। अब नेल को
सब के दवाई मिल गई।
फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सीआर के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सीआर को एडजस्ट किया जाता है कि गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सीआर को एडजस्ट किया जाता है कि वो गोल दिखे, और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है, इस तरह से सीआर को एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है, और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हो इसका बढ़िया रिडक्शन हुआ है, 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the bone out inside the intermedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the epi view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the retrocenter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make a space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we remove this bone out, and then after reduction of it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept. We did drilling up to the lower end of the femur, and finally we remove this fracture with the help of power beam of 11 millimeter. Because the patient is old one, so reaming is easy. It is just to measure the size of the intramedullary canal, the diameter of the intramedullary canal, so what size of the nail should be introduced so that it can fit in the intramedullary canal. The fitting nail can be introduced. So this is the purpose of reading. Because the patient is old-born osteoporotic, throughout the nailing process, reaming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been linked up to the lower upper end of the patella. As you can see in the CR picture, you can see in the CR picture it is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, 11 millimeter nail on cheek. And finally I am hammering the nail inside the intramedullary canal and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented. size nail up to the upper bone of the back cavity. Good position, the fracture is reduced in both view, in the oblique view and lefty view and lateral view. And when I will remove the guide wire before proximal locking, and now I am doing proximal locking after removal of the guide wire, and now I am tightening the screw, the second screw in the proximal bracket. Anesthesia was wearing off, so it was accepted, and you can see that both in the AP and lateral view, the both proximal as well as the distal screw are in place and in proper position. And now I am going to close the wound after forceful wash of the wound so that
ठीक है जाएगी
all the now I am closing the wound after forceful wash of the wound. Now the wound has been. Hello friends, I am Dr. RCT orthopedic surgeon Saprapi. Iliac spine down to the table and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the one owl in correct position after confirming the entry point in CR picture, both in AP and lateral view. So this is the AP view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position going medial. Remove the owl. Remove, and the size is 11 millimeter diameter. PFN at 2 nails, and now I am giving an incision for introduction of the spiral blade, and this is the buttress nut. My assistant is tightening it, and so that it touches the lateral wall of the femur. And size of the nail selected. So I have rimmed up to the proper distance, and now I am hammering the spiral blade after confirming it central position in both views. and I am compressing this spiral blade by clockwise movement, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced. After confirming it in CM picture, I am drilling with the power drill, both lateral and the first cortex is drilled, and I will stitch the skin and close we plan the surgery for this patient. Thank you everybody. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number two is there is always chance of radial nerve injury, as it is a complication for the interlocking nailing of humerus. It is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spinal root. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remote, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies, whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeon. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the drill bit or TY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number three controversy is because it is non-weight bearing bone, so one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1.
always stronger than one. If it is just like the two kidney present in human body, if one fails, other start working. So, and two engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So, the fixation is better by two screw proximal and two screw distal. So, friends, these are the advantages of locking nailing over the plating of the humerus, and these are the myths, and these are the controversies whether two screws should be put proximal and whether the distal, what position should be used in this talk. And let us get tuned for the next video and subscribe my channel for more updates. आज मैं आपको इंट्रामेडुलरी नेलिंग ऑफ लॉन्ग बोन ऑफ ह्यूमन बॉडी के इतिहास के बारे में बताऊंगा। सबसे पहले मैक्सिको में 16वीं शताब्दी में रेसिनस वुड यानी कि लकड़ी का उपयोग इंट्रामेडुलरी कैनाल में डालने के लिए होता था ताकि हड्डी का जुटान हो जाए, लेकिन उसे असफल होना ही था। कीटाणु संक्रमण के कारण वो असफल हो गया। उसके बाद आइवरी हाथी दांत का उपयोग होता था, क्योंकि उसका रंग उस आदमी की हड्डी से मिलता जुलता था। तो ऐसा विश्वास था लोगों का कि 18वीं शताब्दी में ऐसा विश्वास था कि बायो फ्रेंडली और बायो कंफर्टेबल होगा, तो हड्डी के आदमी के हड्डी के साथ घुल मिल जाएगा। 1939 to 1940 में असली क्रांति इंट्रामेडुलरी नेलिंग के क्षेत्र में हुआ। जब कुंसर ने, जर्मनी का सर्जन था, उसने सबसे पहले कुंसर नेल बनाया और इसे के नेल भी कहते हैं। ये के नेल है, देखिए ये निकालने के लिए ऊपर में एक छेद है और इसमें निकालने वाला औजार को फंसा करके निकालते हैं और डालने के लिए ऊपर से डालते हैं। 1939 to 40 में इस नेल का उपयोग सेकेंड वर्ल्ड वॉर में सैनिकों को ट्रांसपोर्ट करने के लिए जल्दी से जल्दी उपयोग किया जाता था। क्योंकि फर्स्ट वर्ल्ड वॉर में थॉमस नेल और प्लास्टर का उपयोग किया जाता था, जिससे बहुत दिन तक मरीज को, सैनिकों को बेड रिडन रहना पड़ता था और बेड सोर और निमोनिया, किडनी फेल्यूर और पल्मोनरी इन्फेक्शन का चांस रहता था। और इस नेल के आने से सेकेंड वर्ल्ड वॉर में जो सैनिक विभिन्न देशों से जर्मनी गए थे सेकेंड वर्ल्ड वॉर में भाग लेने के लिए, वे अपने अपने देश लौटे तो उनके देश में देखा गया कि इस नेल का उपयोग कुंसर ने किया था सेकेंड वर्ल्ड वॉर में, और जल्दी से जल्दी मरीज उसमें खड़ा हो जाता था और चलने फिरने लगता था और ट्रांसपोर्टेशन आसान हो जाता था और हड्डी भी जल्दी टूटती थी। लेकिन यह लॉ नहीं था। तो 1950 में ही कुंसर ने ही ये आइडिया दिया था कि अगर ऊपर नीचे इसको लॉक कर दिया जाए तो रोटेशन नहीं होता। ये रोटेशन हो रहा है, ये घूम रहा है अगल बगल और ऊपर नीचे भी नहीं जाएगा, तो ज्यादा रिजिड और स्टेबल फिक्सेशन होगा। तो 1950 में आइडिया कुंसर ने ही दिया था और इस नेल को भी सेपरेट होता है और क्लोवर लीफ सेपरेट होता है। उसके बाद बीच में 1950 में रीलिंग का कंसेप्ट आया ताकि कॉन्टैक्ट एरिया जो इंट्रामेडुलरी कैनाल का है और नेल से ज्यादा कॉन्टैक्ट हो और मोटा नेल डाला जा सके।
ताकि ज़्यादा रिजिड और स्टेबल फिक्सेशन हो सके और जल्दी से जल्दी मरीज को हम लोग चला सके। तो ये कॉन्सेप्ट था 1950 में और 1970 में ग्रॉस एंड केम्प जो ने ग्रॉस एंड केम्प ने सॉलिड ने वो इंटरलॉकिंग नेल का इंट्रापेटलर रूप से 1990 तक ये इंट्रापेटलर रूप से इस नेल को डाला जाता था टिबिया फ्रैक्चर में। तो उसके बाद फीमर फ्रैक्चर में भी इसको डाला जाता था। ये फीमर नेल है और दो ऊपर छेद है और दो नीचे छेद है। इसको भी जीप के थ्रू लॉक किया जाता था। बाद में देखा गया कि नीचे के छेद लॉक करने में परेशानी आती थी, इसलिए फ्री हैंड टेक्निक से आजकल डिजिटल लॉकिंग किया जाता है। सो ये फीमर नेल है और ये प्रॉक्सिमल फ्रैगमेंट का एंटीरियर एंगुलर डिफॉर्मिटी बढ़ जाता है ड्यू टू पुल ऑफ द पैटेला। तो इसको न्यूट्रलाइज करने के लिए, पुल ऑफ पैटेला को न्यूट्रलाइज करने के लिए सुप्रापेटलर नेलिंग का कंसेप्ट आया। इससे 1996 में टोर्नेटा एंड कोलिंस ने ये कॉन्सेप्ट किया सेमी एक्सटेंडेड पोजीशन ऑफ द नी में, नी के द्वारा अगर नेलिंग किया जाए सुप्रापेटलर नेल रूप से, तो ये जो डिस्प्लेसमेंट हो रहा है 90 डिग्री फ्लेक्शन करने के कारण इंट्रापेटलर रूट नेलिंग रूट के द्वारा नेलिंग करने में उसे रोका जा सकता है, क्योंकि वो पैटलर पुल जो है वो न्यूट्रलाइज हो जाता है सेमी एक्सटेंडेड पोजीशन में रखने से। तो फर्स्ट टाइम इम्प्लांट का खर्च पड़ता था। तो गरीब मरीजों के लिए छोटे छोटे नर्सिंग होम में इसे यूज नहीं किया जा सकता था, क्योंकि उसका कॉस्ट जो है कॉर्पोरेट हॉस्पिटल वाले ही क्लियर कर सकते थे। इवन सरकारी हॉस्पिटल में भी, छोटे छोटे हॉस्पिटल में, डिस्ट्रिक्ट हॉस्पिटल में इसे नहीं किया जा सकता था, क्योंकि एक ऑपरेशन के लिए उतना सरकार भी खर्च वहन नहीं कर सकती है, उतना महंगा इंस्ट्रूमेंट। उसके बाद डॉक्टर RC ठाकुर ने, डॉक्टर ठाकुर इनोवेटिव टेक्निक को इनोवेट किया, जिसमें फ्री हैंड टेक्निक से अपर एंड लोअर लॉकिंग किया जाता है और जीप का उपयोग नहीं किया जाता है। और PFN सेट से ड्रॉपर एंड प्रोटेक्टिव स्लिप को यूज किया जाता था, क्योंकि स्पेशल इंस्ट्रूमेंट सेट का लंबाई चौड़ाई जो ड्रॉपर एंड प्रोटेक्टिव स्लिप यूज किया जाता है, तो उसका लंबाई चौड़ाई और उसका डायमीटर जो होल होता है उसको डालने के लिए, रिंग करने के लिए, सो सेम ही था। तो उसको PFN सेट का ड्रॉपर एंड प्रोटेक्टिव स्लिप यूज किया और एक कलर कोडेड टिबियल नेल एक्सट्रैक्टर, टिबियल इंट्रापेटलर रूट का टिबियल नेल एक्सट्रैक्टर है, जिसे कलर कोडिंग कर दिया गया। इसके 4 फेस है, अपर एंड में 4 फेस है, जिसमें A, B, C, D लिखा गया है। आप कुछ भी लिख सकते हैं, इसमें आप अपने स्टाफ का नाम भी लिख सकते हैं। और D जो है वो पोस्टीरियर सरफेस पे जाएगा। तो इस तरह से ये रिलेशन बना रहता है। तो जो इंस्ट्रूमेंट सेट का कॉस्ट 0 हो जाता है और नेल वही रहता है जो उनका पैटलर रूप से डाला जाता है। अतः यह बहुत कम खर्च में हो जाता है इंस्ट्रूमेंट सेट का खर्च। लॉक करने के बाद जो है इसको नेल को डालते हैं और ऊपर लेवल करने के बाद जो है इसको नेल को डालते हैं अपर लेवल ऑफ द कॉलर कोडिंग किया जाता है और इसमें एक बीच में इंस्ट्रूमेंट के बीच में RCT नेल इंट्रोड्यूसर को पोजिशनर में सेंटर में एक होल होता है जिसमें टॉमी बार लगा करके नेल को पोजीशन में रखते हैं। जब हम हैमर करते हैं तो धीरे धीरे नेल रोटेट करता है आइदर एंटी क्लॉकवाइज या क्लॉकवाइज। सो हिस्ट्री बहुत ही रोचक हिस्ट्री है इंटरलॉकिंग नेलिंग का।